Welcome to Roadmap to Residency. Hello everyone, I'm Abhiraz. Welcome to our Club 250 Matchmaker sessions. Here in this video, we will be discussing about the few important reproductive system disorders. So which of the following is a common histopathological feature associated with endometriosis? A 28-year-old woman presents with complaints of pelvic pain, particularly during her menstrual periods. She also experiences pain during intercourse and has noticed heavy menstrual bleeding. On pelvic examination, the physician notes the presence of tender nodules on the uterosacral ligaments. The patient's medical history is unremarkable and she has never been pregnant. Which of the following is the most common a common histopathological feature associated with endometriosis? Hyperplasia of the endometrial glands, chronic inflammation with granulomas, squamous metaplasia of the endocervix, ectopic endometrial tissue with hemosiderin-laden macrophages, atrophy of the endometrial lining. So, option number D is the correct answer. So, endometriosis is a condition in which endometrial-like tissue is found outside the uterus, commonly in the pelvic peritoneum and ovaries. The histopathological hallmark of endometriosis is the presence of ectopic endometrial glands and stroma in areas outside the uterine cavity. Over time, the cyclic bleeding of this ectopic endometrial tissue leads to the inflammation, fibrosis, and the accumulation of hemosiderin-laden macrophages. Hemosiderin is a byproduct of the breakdown of hemoglobin from the extravasated blood, and its presence is indicative of chronic bleeding. So endometriosis is a disease in which endometrial glands and stroma implant and grow in areas outside the uterus, most commonly in plants that found in the pelvis. The lesions may occur at distant sites like pleural cavity, liver, kidney, gluteal muscles, or bladder, etc. sites. So Sampson's theory, which include the retrograde menses and peritoneal implantation. So most women have a retrograde menstruation. The Mayer's theory indicates coelomic metaplasia. Also, since there is involvement of the uh, pleural cavity or the pleural spaces, so that is being explained by the coelomic metaplasia. Alban's theory, which tells us that the hematogenous or lymphatic spread to the distant tissues may be the other a mechanism of involvement of distant sites, and due to some immunogenic defect, there may be development of endometriosis. So pelvic pain is the most common feature. The frequency is that it is cyclic, variable length prior to and after the menses. And if it is acyclic, then it is constant and unrelenting. It may be associated with other activities like dyspareunia, dysuria, or dysphagia. So you can remember this by 4 Ds. So dyspareunia, dysuria, dysphagia, and dysmenorrhea. Other sites of pain include muscle regions and distant tissues. So infertility is also one of the most common complaint. So it may be due to adhesions, distortion of normal anatomy, or prevention of a sperm-egg interaction. In minimal to mild disease, it may be mild infertility, and the mechanisms are unknown. The patient, while you physical examining the patient, you can find out that there are tender nodules along the uterosacral ligaments or in the cul-de-sac, especially just before the menses. The pain or induration without nodules, commonly in the cul-de-sac or vaginal septum. Uterine or adnexal fixation or an adnexal mass may be present. So diagnosis, the hard and fast rule or the most diagnostic is a laparoscopy, which is the direct visualization of implants, but we can also diagnose it clinically or through a simple USG. The imaging of endometriosis, so if the MR appears to be the best, okay, ultrasound is helpful in office setting. The biochemical markers lack specificity in case of endometriosis. Management of pain is by surgical treatment. We can do it by ablation of endometrial implants, lysis of adhesions, or ablation of uterosacral nerves. We can also do a medical management by oral contraceptives, GnRS agonists, alternating with GnRS agonist and OCs, aromatase inhibitor. So the oral contraceptives, they act by the interaction between the estrogen and progesterone, okay? And if we can just block the estrogen production from the ovaries, then it can just block the endometriosis progression. Removal of disease is by surgery. It can be due to ovulation induction, and medical suppression of ovarian function has shown no benefit regarding the treatment of infertility in case of endometriosis. So, which of the following is a first-line pharmacological therapy for the management of endometriosis-associated pain? Oral contraceptives, GnRS agonist, NSAIDs, danazole, or aromatase inhibitor. So oral contraceptives, specifically combined hormonal contraceptives containing both estrogen and progesterone, are considered first-line pharmacological therapy for the management of endometriosis-associated pain. These medications work by suppressing the ovulation, reducing the menstrual flow, and inducing atrophy of the endometrial tissue outside the uterus. The goal is to create a hormonal environment that minimizes the stimulation and growth of ectopic endometrial tissue, thereby alleviating the symptoms such as pelvic pain and dysmenorrhea. So which of the following is a common metabolic feature associated with polycystic ovarian syndrome? Now, if you see this sort of question, that's why I tell you to read the last line first. So if you see this sort of questions, then you do not need to read even the rest of the question stem. So hypercalcemia, hyperlipidemia, hypoglycemia, hyperkalemia, hyponatremia. So hyperlipidemia is a common metabolic feature associated with polycystic ovarian syndrome, and women with PCOS often exhibit insulin resistance, leading to increased insulin levels. Insulin resistance can contribute to abnormalities in lipid metabolism, resulting in elevated levels of triglycerides and low density lipoprotein, cholesterol, and decreased levels of high density lipoprotein. This dyslipidemia is considered part of the metabolic syndrome frequently seen in individuals with PCOS. So this is the pathogenesis and clinical finding of PCOS. So due to the genetic susceptibility, lifestyle, there may be increase in the insulin resistance, and there can be intraperitoneal cavity accumulation of visceral fat, secreting estrogen and inflammatory mediators. Now, due to the genetic susceptibility, there can be increase in the serum luteinizing hormone compared to the follicle stimulating hormone. And it can be also due to the increased estrogen through the intraperitoneal accumulation of visceral fat, which can ultimately stimulate the pituitary production of LH. So there is LH to FSH ratio disproportion. Then this can cause the decreased conversion of testosterone to estrogen by FSH activated granulosa cells. And the theca cells make the increase in the androgens. And ultimately that will lead to the state of hyperandrogenism. Whenever there is a state of hyperandrogenism, there is increased androgens in the serum. And if we do the tissue culture, we can find the increased theca cell androgen production. Also, the increased androgen and estrogen too early in the menstrual cycle will cause the early suppression of FSH, and it will cause cessation of follicular growth, which means that the follicle was in the pathway of maturing, but due to the sudden cessation of follicle maturation, the follicle maturation is stopped in the midway, and that's how it formed a polycystic ovaries. And it can further lead to infertility, dysfunctional bleeding, risk of endometrial cancer, or irregular menstruation. The state of hyperandrogenism can ultimately lead to hirsutism, skin thickening, or acne. And increasing the insulin resistance is the reason behind the type 2 diabetes mellitus most commonly seen or very commonly seen in the patient with PCOS, and is a very common question to be asked in the USMLE examination. And the acanthosis nigricans can also be due to the insulin resistance, or we can say increased insulin production. So management of PCOS related infertility. So if the BMI is less than 30, then we need to go with letrozole, clomiphene citrate. And if it fails, then we have to go with gonadotropins or laparoscopic ovarian drilling. If not, then we have to go for in vitro fertilization. If the BMI is 30 to 35, then first we need to consider weight loss. If the BMI is more than 35, then also we need to first consider weight loss. So diagnosis of PCOS in adolescent girl. So so we can go with biochemical and or clinical hyperandrogenism, where there is increased plasma androgen level, hirsutism, acne or hair loss, or if the patient is complaining of oligomenorrhea, or if the patient is complaining of polycystic ovary morphology in the ultrasound examination. Then we go with treatments, which can be lifestyle changes, estrogen progestins, or insulin sensitizers, or you can say anti-diabetic drugs. Thank you for watching. Keep studying hard.